200 scientists from over 30 countries are urging the World Health Organization to take more seriously the possibility of the airborne spread of the novel coronavirus as case numbers rise around the world and surge in the United States. In a forthcoming paper titled, "It is Time to Address Airborne Transmission of COVID-19, 239 signatories attempt to raise awareness about what they say is growing evidence that the virus can spread indoors through aerosols and linger in the air and can be infectious even in smaller quantities than previously thought. This as the WHO is warning that countries won't reach their HIV/AIDS goals as many report stockouts of antiretrovirals. To talk about this and the situation back home, we're joined now by vaccinologist at Witwatersrand University, Professor Shabir Madhi. Professor Madhi, a very good evening to you and thank you so much for speaking to us. I'd like to get your thoughts on this warning of airborne transmission. Is it cause for alarm?
So good evening to you. And I think the short answer is that yes, it is cause for alarm. And in fact, it's probably more than just cause for alarm. I think as we've been learning over the past 2 months at least, it appears that the dominant mode of transmission of this virus is not necessarily by what we call fomite spread, that is people coming into contact with contaminated surfaces, but rather because of direct inoculation between people, as well as the possibility of inhalation of contaminated particles that remain airborne for up to about 5 to 12 minutes, especially in poorly ventilated areas. I think what's transpiring in South Africa in terms of the rapid rate of spread of the virus as well.
Right. Professor Madhi said that it's tiny respiratory droplets that infected people cough or otherwise release into the air. And as you say, they survive anything from 5 to 10 minutes. Are they detectable? Because I'd imagine that this may be part of the problem, why this is not part of the protocols that were widely given by the WHO to protect people.
Correct, but I think more recently there has been a shift even on the part of WHO in terms of recommending the use of the face mask as an example. And the purpose of that face mask is really to reduce the ability of a person to aerosolize these contaminated droplets, including to reduce the ability of a person that is infected to transmit directly to another person that's in close proximity. So even though WHO hasn't made a position that airborne transmission is possible, I think the type of recommendations they're making basically aligns to the concept that you do get airborne transmission as well. It might be the type of transmission, but it probably is a reality.
So just explain to us, Professor, the difference between large drops and, as I mentioned, the smaller respiratory droplets. How do you detect it, especially on surfaces? The culture virus and how it transmits, as you mentioned, the time period. Just take us through all of that.
So when we talk of large droplet spread, it's that the large droplets that are released, which because of gravity would basically settle on surfaces, most commonly in surfaces where people are more in contact with, but anywhere in your environment. So when a person coughs or even breathes, they release these large droplets. When we talk of micro droplets, it's really invisible to the eye, and which basically means that you're not too sure you're not certain whether you're actually expressing those sort of droplets or not. It's naked to the visible eye. Now, with the large droplets which settle on surfaces, those are considered to be contaminated surfaces. If someone touches those areas, and then touches themselves, especially at the mucous membranes, their eyes, their nose, as an example, they can self-inoculate themselves. On the other hand, with these other droplets which are spread in the air itself, there's one of two modes of acquisition. It's either that you're close to someone that's coughing or sneezing, and those droplets actually land directly on you, and you become infected. Alternatively, those droplets remain suspended in the air, and someone walks into that place, as an example, without a face mask, might actually inhale those droplets and consequently become infected. But these are very, very tiny droplets which themselves would eventually settle onto surfaces as well.
And not to cause panic, but we're trying to understand this, Professor, because many more grades have gone back to school, as we mentioned earlier on, that some schools had to turn learners back because they didn't have personal protective gear. So how do we best sanitize surfaces and what areas should we concentrate on? Professor Saluji yesterday saying that we shouldn't worry too much about paper, but what should we be worrying about if we're sanitizing surfaces, workplace areas, etc.?
So the surfaces that you're wanting to sort of cleanse are those surfaces which people come commonly into contact with. So as an example, your desktop or your window or your doorknobs. So any surface which people are commonly in contact with, those are the surfaces that you're wanting to focus on. It makes little sense to be focusing on the floor as an example, because very few people would go down on their hands to touch the floor and then subsequently rub their eyes or wipe their nose as an example. So it's really the commonly touched surfaces that you're really looking at in terms of sanitizing on a regular basis. But I think another critical thing for schools, especially in terms of this notion of airborne transmission, is the need for there to be adequate ventilation. And this is the time when you're wanting those windows to be open. Unfortunately, be it winter, those windows need to be open to allow adequate ventilation in that environment, which sort of allows for a dispersion of those contaminated micro droplets that might be in the atmosphere.
What have we learned in terms of SARS and MERS? In the technical advice that the WHO is giving, what have we learned from these two viral infections that will help us, SARS and MERS?
Right, so I think what we're experiencing right now is very different from the experience with SARS as well as with MERS. And in particular, a big difference is the efficiency of transmission of this virus. The SARS coronavirus 2, which causes COVID-19, seems to be much more efficient in terms of its transmission. Another big difference between this virus and the previous two coronaviruses, MERS and the SARS virus, is that with MERS and the SARS virus, it seemed that a person was most infectious after they became symptomatic. Whereas with the SARS coronavirus 2, it appears that a person is most infectious at least 3 days before they become symptomatic and up to about 5 to 6 days after the onset of symptoms. So it was easier to manage the MERS virus as an example because you really needed to focus on the individuals that were already symptomatic, whereas it becomes much more difficult to contain or control the spread of the SARS coronavirus because people that are not symptomatic are still spreading the virus. In fact, that's probably when they're the most infectious, including people that remain completely asymptomatic. They too appear to be able to spread the virus. So these are very different viruses in terms of their ability to transmit and cause people to become infected.
And just looking at vaccines, prospects thereof, I know we've started our own trials here, but Brazil is becoming a key testing ground for this vaccine. What makes Brazil so strategic and what can we learn from what they've done thus far?
Right, so the study that's being done in Brazil is actually evaluating exactly the same vaccine that we're evaluating in South Africa. So there's no difference between these two studies in terms of the vaccine that's being evaluated. And we're pretty much at a similar stage in terms of the outbreak. So I think the South African study is probably as equal in importance to the study that's being conducted in Brazil right now. And for both of these studies, it's very well that we might get an answer around about the same time as to whether this vaccine protects against COVID-19 or not.
Thank you so much for speaking to us and sharing your insights. Vaccinologist at Witwatersrand University, Professor Shabir Madhi.